Yes, thank you. Now let us have a look at placenta abruptio. Sometimes we prefer to call abruptio placenta. Now, this can be defined as partial or incomplete placental detachment at or after 26 weeks of gestation and before delivery in a normally situated placenta. And as you can see here, this diagram showed us the placenta with blood due to detachment that is accumulating within the retroplacental space. And sometime in placenta abruptio or abruptio placentae, you can have bleeding that can be seen coming out through the vagina. That is what we call revealed bleeding. Now, there are notable risk factors of abruptio placenta, and these include previous history of abruptio placenta, and this has been found in many studies. The other one is direct trauma to the abdomen. In most cases, road traffic accident is a very common occurrence, and these mothers can easily have blunt abdominal trauma and risk for placental detachment. The other thing is hypertensive disorder in pregnancy. This in particular is preeclampsia and eclampsia. Mothers who have preeclampsia and eclampsia, please let us take note that they can develop abruptio placenta. The other thing is polyhydramnios. This could be attributed due to expansion because of the fluid that is going to be accumulating within the amniotic sac, and so we have a lot of fluid that accumulates. This risk these mothers from getting placenta abruptio. The other things that I've actually noted there is short cord, chorioamnionitis, and also uncontrolled rupture of membranes. Now, let us just go ahead and see what we call differential diagnosis. We have very many causes, and if you think it is not abruptio placenta, what do you think could be other causes? We can have placenta previa, which is the second commonest cause of antepartum hemorrhage, contributing about 20%. Abruptio placenta being the most common, contributing to about 30%, as I said before. We also have uterine rupture or rupture uterus is also a common occurrence, but yes, it is serious, but it occurs also commonly. We also have vasa previa. Vasa previa here is when we have the fetal vessels that traverses through the internal os, and sometimes they can be actually attached to the membranes. And this, when there's any abrasion within the vessel can start bleeding tremendously. Other causes could include trauma. I've just talked about trauma to the abdomen. Others include degenerative fibroids and many others that I've listed there. Yes, having known the risk factors, what abruptio placenta is, it is important to appreciate the management of abruptio placenta. Always and always and always, members, let's call for help. Let us emphasize on this because it is actually teamwork that helps us to maximize the outcome of our mothers. If it happened that there is a suspected case of abruptio placenta right now, all of us will abandon this meeting, will abandon this CME, will abandon this getting together to go and help this mother once we were called. Therefore, as you are calling, you make sure that you initiate continuous fetal heart monitoring. Sometimes we need to put these mothers on what we call CTG or cardiotachography so that we can keep monitoring the fetal heart and the fetal condition. The other thing is IV access is critical. You can put one IV access with wide bore cannulas, 16 gauge, or you can put two if the patient presents with signs of shock, which include restlessness, hypotension, and also hemodynamic changes. But also we noted that there could be coagulopathies or coagulopathy disorder. It is important to notify the anesthesia team because this team will help us in the management when these patients are hemodynamically unstable. It will also help us in managing patients with bleeding disorders, as most of these patients may require ICU care or intensive care unit services. Also, when you as a clinician will need to perform an emergency cesarean section and you need this anesthesia team to come in and help, we need to keep maintaining these patients on IV fluid all the time. IV fluids here, we are talking about crystalloids, normal saline or Ringer's lactate. And we aim at maintaining the urine output of 30 mils per hour. And this is the normal urine output when it is more than 30 mils per hour. We also need to think about delivery and plan and anticipate delivery as soon as possible. What I've projected here is the algorithm for the management of abruptio placenta. We have, in case you diagnose or you suspect abruptio placenta, please try to find out whether the fetus is dead or the fetus is alive. And if the fetus is dead, unfortunately, then you can do even vaginal examination, and therefore decide what mode of delivery you can actually ascertain. If vaginal delivery is contraindicated, then what do? You do cesarean section. However, if vaginal delivery is not contraindicated, you go ahead to rupture the membranes, augment that labor, and deliver this mother, while you continue to monitor the vitals of the mother post-delivery or in preperium. The other thing is, if the fetus is alive, what do? Vaginal examination, digital vaginal examination is not always advised unless you have ruled out what we call placenta previa. However, if the cervix was already dilated more than 7 centimeters, or it is fully dilated, and vaginal delivery is possible, go ahead to deliver this mother. And if the fetal heart, the fetal head is not engaged, or the fetus is in distress, or even there is a contraindication to vaginal delivery, or this fetus is remote from delivery, that is remote from term, what do? You make sure you optimize the mode of delivery and deliver this baby. And even post-operatively, you ensure that you monitor and record the vitals, which include urine output, maternal pulse, and also be ready for the occurrence of postpartum hemorrhage, because it's a common occurrence and high risk for these other patients.